Welcome, everyone, to the PCPCC NASHP webinar, State Innovations, Updates from the Minnesota Healthcare Home Initiative. I am Neva Kaye, Managing Director of Health System Performance at the National Academy for State Health Policy, or NASHP, and I will be moderating today's webinar. I'd like to say thank you to the PCPCP for orchestrating this webinar and including NASHP in this important discussion. NASHP's extensive work on Patient-Centered Medical Home, or PCMH, began in partnership with the PCPCC, and I am pleased to be part of this webinar, which is the latest product from that partnership. This month's theme at the PCPCC has been focused around the topic of state innovations. And today's webinar will examine emerging findings from Minnesota's evaluation of its PCMH program called the Healthcare Home Program. This is an incredibly important topic. As many of you already know, there is substantial interest from both public and private payers in developing patient-centered medical home programs as a means of achieving IHI's triple aim of improved health outcomes, lowered per capita cost, and improved quality and patient satisfaction with care. Since 2006, the majority of states have implemented PCMH initiatives into Medicaid and CHIP. Currently, 29 of those states are making payments to support PCMH programs in Medicaid and CHIP, and 18 have active public-private multi-payer initiatives. These states are all pursuing the PCMH as an investment in primary care. In order to continue those investments in patient-centered medical homes, we will need data that shows that the PCMH is foundational for primary care delivery that will ultimately achieve these AAA goals. Evidence is beginning to be released as evaluations of early PCMH programs produce results. Some findings have been positive, some have been neutral or negative. Today, we are going to hear about some promising results emerging from the evaluation of Minnesota's Healthcare Home Program, one of the earliest multi-payer PCMH programs. The Minnesota Department of Health and Minnesota Department of Human Services, in conjunction with the University of Minnesota, the Healthcare Home's independent evaluator, recently released an evaluation report of this initiative to the Minnesota Legislature. To tell us more about the initiative and to provide highlights of the promising results featured in this report, we will hear from Marie Mays-Verrees and Dr. Douglas Hooley. At the end of their presentations, the audience will have about 15 to 20 minutes to have their questions answered by the two presenters. Marie Mays-Verrees is the Director of Healthcare Homes at the state of Minnesota. Marie has led the implementation of healthcare homes legislation for the Minnesota Department of Health and the Minnesota Department of Human Services as a joint government-private sector project since 2008. Marie has a master's degree in Health and Human Services Administration from St. Mary's University and a bachelor's degree in nursing from the College of St. Benedict. Dr. Douglas Hooley leads the team evaluating Minnesota's Health Home Initiative. He is Professor of Organizations and Management at the University of Minnesota School of Public Health. For complete bios of both speakers, please visit either the NASHP or PCPCC websites. Thank you to both of our presenters for being part of our conversation today. NASHP is an independent academy of state health policymakers working together to identify emerging issues, develop policy solutions, and improve state health policy and practice. We have been working since 2007 to foster and track state-based PCMH programs. We invite you to visit our website to find and access a multitude of resources related to patient-centered medical homes, multi-payer PCMH initiatives, and accountable care organizations. Before I turn it over to Marie and Doug, I want to bring a few important announcements and housekeeping items to your attention. Today is the last day to register for the $100 early bird discount for PCPCC's Western Regional Conference in Denver, Colorado on June 9th to 10th. More details are available on the PCPCC's website. PCPCC's next national briefing is on April 24th at 1 p.m. and will provide an overview of the PCMH initiatives from states participating in the Multi-Payer Advanced Primary Care Demonstration Program. Another state-focused resource developed in partnership between PCPCC and State Reform, NASHP, was just released yesterday. This chart documents medical home activity within the 2014 health insurance exchanges. You can access this chart from the State Reform website. After Marie and Doug's presentations, there will be an opportunity for audience questions. To do this, Submit your questions in writing using the drop-down question box on your screen. Also, please note that slides and the recorded presentation will be posted to PCPCC's website within the next 24 hours. And with that, Marie, take it over.
Well, good morning, everybody, from snowy Minnesota on this lovely April 17th. It's my great honor to share with you the work that we're doing in Minnesota on our patient-centered medical home, or the healthcare home program, as we call it in the state of Minnesota, as we look to really link communities and primary care in our efforts to implement coordinated patient-centered care. Just a little background about our health reform work in Minnesota. One of the things that you should know is that as we implemented the patient-centered medical home in Minnesota, we implemented it among a package of health reform activities. So in 2008, when our legislation was first initiative, we looked at implementing a package around prevention, which is our statewide health improvement program. It really looks at long-term healthy behaviors to reduce obesity and tobacco use. Care delivery redesign, which included not only healthcare homes, but quality incentive payments. Our program that was initiated in 2010 for Medicare Integrated Health Partnerships, or Medicaid ACOs. Looking at transparency and the implementation of our statewide quality improvement measurement system, which really allows our PCMH program to have data that we can look at consistently across our state, as well as our health insurance exchange, and lastly but not leastly, our administrative simplification programs, which includes our Office of Health Information Technology and our statewide project to increase interoperability and electronic health records. Okay, let's see here. It's not moving. There we go. So you'll see here in Minnesota, oops, let's see here. I'm trying to go up. You'll see here in Minnesota that we currently have 332 certified healthcare homes, which is 42% of the primary care clinics in Minnesota. However, that serves 3.3 million patients, which is about 60% of the population in the state of Minnesota. And we currently have around 3,500 certified clinicians. And Dr. Julia is going to talk more about the clinicians and their distribution. So one of the things that we did in the state of Minnesota in 2008 is we decided to implement healthcare home as a statewide initiative. We had already done a pilot with children with special health needs, implementing medical home for the previous 5 years, and we knew that this was the direction we wanted to go as, in implementing patient-centered coordinated care. So we actually started with a statewide approach and an extensive public-private partnership. The Department of Health and the Department of Human Services are the implementation leads for the healthcare home program in the state of Minnesota. In 2008, we developed standards through a community-based engagement, and we actually implemented our own healthcare home standards, as well as implementing a certification process in Minnesota at the direction of our state legislation. We implemented tools such as the statewide learning collaborative, integration of community partnerships, build on our state HIT and HIE project, use those measures that I spoke about earlier to really do benchmarking and to implement accountability within our healthcare homes, as well as the development of our payment methodology and our statewide evaluation, which we're going to hear about. The foundation, though, to all of our work in the state of Minnesota is our focus on patient and family-centered care. And we have integrated patient and family-centered care concepts into all of our work, including all of our advisory committees at both the state level and within our certification process, within our standards, within how we do evaluation around patient-centered care. And we feel that this has been a real benefit to how we have rolled out our patient-centered medical home in Minnesota. Now, one of the things that we look at in Minnesota, since we're implementing at a statewide perspective, is not only how many certified healthcare homes, but where they are located across the state. And we have our nursing staff, and we work with a number of other organizations to do practice facilitation and to do capacity building across the state. So you'll see that 64% of the counties in the state of Minnesota actually have a certified healthcare home, but some of our counties per 100,000 people may be as low as 3.17 versus other counties that have 6.70. So this is something, or even 8.55 when we're looking at southwest Minnesota. So this is one of the things that we have really watched carefully in implementing healthcare home from a statewide perspective. Now this is a look at our standards, and I'm not going to go into great detail around our standards because they aren't that different than some of the other standards that have been implemented through NCQA and others after us. But I would say just a couple things that we think are most transformational. While we require continuous access, 24-hour access, we also require access to the patient's health records, whether that's electronically or in paper. We have a care coordination program that requires direct connection between the primary care provider and the care coordinator and a direct relationship with the patient. We require care planning, an active living care plan with patient-centered goals. And sometimes we coin that as refrigerator ready, and making sure that it's a tool that patients and families can really use, especially for those patients that have those chronic and complex conditions. The use of population-based registries, and we started out with a population-based approach where clinics really identified those patients that really would benefit from additional care coordination. And lastly, and certainly not leastly, but a strong focus around quality and integrating patients and families in the quality work. A few other things that I want to mention is that we developed a multi-payer payment methodology, and our goal in the state is to continue to move forward to build critical mass. We started with population management, and we use a tiering risk complexity process in doing our payment. And we really believe that our payment methodology is to build infrastructure within primary care and is the foundation to future ACOs and total cost of care payments. And in the diagram you can see those payers that are mandated through our state legislation to pay healthcare home per member per month payments or some kind of payment, as well as we participate in the MAPCP demonstration. And we're continuously evaluating our work, not only our payment methodology, but our work in general. So we have a strong performance improvement foundation based on the triple aim, and we have actually built quality improvement into all of our certification processes as well as into our benchmarking methodology, where over time clinics will become certified based on their improvements and their goals. The healthcare home timeline, I'm not going to go into this in great detail. However, you can see that in stage 1 of the evaluation, that's really been the time that we've built the number of certified healthcare homes from 0 to 322, where we put in the foundation in place, and now the stage 2 evaluation will really continue as we move towards our goal of certifying 513 healthcare homes by the year 2015. We believe that that will be critical mass related to PCMH in our state. Okay, so for further information, feel free to contact us at the Minnesota Department of Health, and I am going to turn this over to Dr. Hooley.
Thank you, Marie. We're very pleased to be able to be doing the evaluation of the Minnesota's Healthcare Home Initiative. And then we have a team from the University of Minnesota, including myself, Michael Finch, Katie White, John Christensen, Rob Krieger, Jessica Zeglin, Sana Lee, and Lindsay Groot. The evaluation was required by state legislation, and there are two components to the evaluation. The first report that we just completed was to examine the initial implementation, answer the question, what are the differences between healthcare homes and non-healthcare homes? And non-healthcare homes are clinics that are eligible to be healthcare homes because they're primary care clinics, yet which have not chosen to become certified. So this first cut here is looking at just differences between healthcare homes and non-healthcare homes. In the Phase 2 report that we're working on for 2015, we will be doing much more analysis looking at clinic self-selection into becoming a healthcare home and trying to parse out causal effects of the healthcare home program in full. So this initial result is promising, but we don't want to make claims that we've come to a final conclusion yet about healthcare homes, which we will be doing. We include a description of the HCH model in our report, enrollee and provider demographics, an analysis of care quality, results from a survey we did about payment implementation, some utilization and cost estimates, and some disparities estimates. Okay. One of the things that we thought was a real strength of the healthcare home model here in the state was a rigorous certification process, and which included direct observation during site visits to assess healthcare home implementation. When we started working on the implementation, I was impressed little things that were done on those site visits, such as when you go into a clinic to certify them, you interview a number of physicians to make sure they all understand what care coordination is and how to work with a care coordinator. So not only do you assess, do you have various structures in, you make sure that you assess that people in the clinic, all the people understand how a healthcare home works. So doing this assessment follows recommended standards for doing evaluation, and it assures evaluation reliability because when we say somebody's a healthcare home, we know that the intervention is there. It has its core characteristics, and that's a real strength of this evaluation. And you can see that we have a cumulative growth in the number of clinics on the gold-colored line shows the growth in the clinics up to end of 2013. And what you also see is the entry clinics becoming certified is lumpy. There will come in what we call application groups that a health system will have a number of clinics that get certified all at once. But the growth is a nice smooth trend, even though the individual components, transformation into healthcare homes is lumpy. So one of the questions that we've asked is, which clinics become certified? And this is critical for understanding future models of self-selection and to control for self-selection into that. So we did a unit of analysis, was clinic by year, and we looked at all healthcare home eligible clinics in Minnesota that reported care quality measures to SQRMS MNCM. That is an abbreviation for the statewide quality reporting measurement system, which has all the measures quality pulled from electronic health records, and that data is collected by Minnesota Community Measurement under contract to the state of Minnesota. We use the healthcare home certification database for the certification data. Certification date, we knew the care quality for the prior year from the SQRMS data, and we used some Medicaid claims data to get costs for Medicaid costs. And we used a logistic regression in a standard diffusion type of model. And our results are clinics are more likely to become certified when they have higher care quality in the prior year. So that's going to be a key thing when we do models of quality to control for the lagged quality of uncertified clinics because that is going to drive their becoming certified. What was interesting, the other thing that drives certification is clinics that have a more complex patients are more likely to become certified, and also clinics with a higher percentage of Minnesota healthcare plan patients, such as Medicaid. Also, the clinics that had a higher percentage of Black and Asian patients were more likely to become healthcare homes, showing that this is actually addressing disparity issues. Larger clinics and also clinics associated with a medical group, which we defined as a group of clinics with 10 or more clinics. Clinics in isolated rural towns were less likely to become certified. And the provider demographics, what we find is that the types of providers in a healthcare home are what one would hope. They're primary care providers, family medicine, and pediatrics providers. Nearly half of the ones in Minnesota provide care within healthcare homes. And the certified healthcare home providers, if you look in just the certified clinics, are mainly family medicine providers with internal medicine and pediatric specialties. So that captures the primary care focus of healthcare homes. The enrollee demographics, we find that we're getting an increasing proportion of the Medicaid enrollees are being served by healthcare homes. And those enrollees who are in healthcare homes also tend to be in the higher HCH payment tiers, which means they're more complex, are persons of color. They speak a primary language other than English and have lower levels of educational attainment. So in other words, you're reaching more disadvantaged populations. Okay, and so a couple slides here to show you the difference. The blue line there shows the white population, and in the non-HCHs at 65.2% of the population. In the HCHs in the healthcare homes, it's only 49.8%, and you can see the higher proportions of disadvantaged populations being served by healthcare homes. And you also see that healthcare homes tend to serve greater proportions of patients who speak a primary language other than English at home. Assessing the care quality. The data that we use to assess care quality came from the statewide quality reporting and measurement system, and it requires physician clinics in Minnesota to submit data on quality measures that are drawn from their electronic health record, and the data are collected and validated by Minnesota Community Measurement. An important point about I'll use the term SQUIRMS, is this includes, the SQUIRMS data measures include commercial, Medicare, Minnesota healthcare plan, uninsured, and self-pay patients. So it's the full population of patients served by primary care clinics. And we had two ways to do our models, and we use both an optimal Grand Slam measure, and that occurs when all the measures, you give credit for meeting the measure when all the components are met. And you can see the components are clinical measures such as controlled HbA1c, controlled cholesterol, controlled blood pressure, no tobacco use, and aspirin use if you have vascular disease. The average care measure is just the average of all the proportion of those number of measures that were met, because there's research that shows that that's a more reliable measure. And so we're testing the quality effects on both. The methods, our initial question was a simple bivariate question: does quality differ between healthcare homes and non-healthcare homes? So we just did a simple bivariate analysis. But there's a lot of work that shows that critiques evaluations of healthcare homes for not taking into account the clustering of patients within clinics, because that affects the standard errors and your inferences about the significance of an effect, and also controlling for patient covariates and controlling for correlates of clinic certification self-selection. So we've also run models that we included the size of the clinic, whether it's a member of a medical group, and whether it's lagged quality for diabetes and for vascular disease when the clinic was uncertified. And so we're hoping that that captures self-selection. These are preliminary results. We do not want to claim that we have a causal inference yet, but we're working toward figuring out what's really happening. And what we see on comparison, little check mark means healthcare homes do better at the 0.05 significance level, and most of these effects were at the 0.01 or lower significance level. So they're very strong effects. The only difference when we adjust for clustering and selection is the depression follow-up at 6 months is not significant. Other than that, we have the same results for depression, asthma care, diabetes care, vascular care, and colorectal cancer screening. Healthcare homes do a better job. We're digging into this analysis more in the next 2 years into our final report. And here's an example. And this is sort of interesting to me because it shows these effects are not large for optimal care quality for diabetes and for vascular care. One of the difficulties in analyzing healthcare homes is the care is fairly well delivered in Minnesota, and so there's not a lot of room for change and improvement over time. But there is improvement, and so we're going to have to be able to dig out how much healthcare homes affected that improvement. Now, so next steps in the care quality that we're going to be doing is we're going to be adding HEDIS measures. We're looking into avoidable readmissions. We're looking into and continuity of care measures as measures of care quality or causes of care quality. We also assessed patient experience by administering 3 surveys, one to 2 clinics, and they were about billing practices. What preparations and decisions did clinics make for billing for monthly care coordination services? Financial practices, whether or not healthcare homes and health systems did prospective financial analyses to determine whether they should become certified or not. And then finally, patient tiering. How do you assign patients to a particular payment tier for payment purposes? We had fairly good response from the number of organizations responding, and some organizations responded for the clinics, all the clinics within their health system. But we had pretty good coverage of the various clinics participating in healthcare home. What they indicated is money is important to healthcare homes and getting paid for care coordination, but it also wasn't a primary driver of healthcare home certification. They were also better able to capture payment due to them for care coordination services from Medicaid and then from Medicare, managed care, and commercial insurers. And this is a multi-payer issue of integrating payment from all the various payments of payers. And on some HCHs do report experiencing cost increases associated with operating the HCH, and we're going to be trying to partition out how much is that related to startup expenses versus operational expenses once you've stabilized everything. So our tiering tool that they're using from Minnesota Department of Health is adequate for current use, but there are improvements being made. Okay, to assess the utilization and cost, we had to attribute patients from Medicaid data to the clinics. And the improvement and attribution has increased over time because of 2 sources of data. One, the healthcare home initiative. When a clinic becomes certified, we know which providers are certified in which clinics, so we can attribute patients to clinics through the providers. And also with the statewide quality reporting measurement system, we can also get data that helps us attribute providers to clinics. That is the reason that the attribution has improved over time. Okay? And one of the issues may be the clinics that the attribution in earlier phases was due to more likely for complex patients who have more encounters. What we found with the cost is that over the period in 2010 and 2011, Medicaid enrollees had higher health care costs per member per year. But lower in 2012, the costs were lower. So in 2012, the enrollees that were in healthcare homes had a PMPY of 2372 compared to PMPY in a non-HCH clinic of 2506. So if we combine the data for all 3 years, we see that the healthcare home enrollees had 9.2% lower costs than enrollees in non-HCH clinics. This is just total medical costs, no other costs. So there were initial significant savings on costs associated with healthcare home. We've done some analyses on why these costs are lower, and what we found is that there are fewer average encounters for emergency departments. Okay, well, hospital inpatient stays was a little bit lower for healthcare homes. It was not significantly lower. Okay, and we are going to be looking more at the data on all these various costs to see what determines why the total overall cost is lower and how those costs combine to get lower costs. So our analysis on disparities is that HCHs are serving enrollees with higher severity medical conditions and disadvantaged populations. We showed those slides earlier. And so what we find is compared to populations of color non-certified clinics, and when also in utilization, populations of color in healthcare homes used fewer ED and ambulatory surgery service and had fewer E&M visits, possibly at the cost of using more professional services. So summary, healthcare homes are associated with greater access to care for disadvantaged populations, greater quality of care, and lower cost as compared to similar primary clinics that are not certified as healthcare homes. Limitations is that this evaluation was over the first 3 years. The first clinic was certified in July of 2010, and we only went through December of 2012 for the certified clinics. Okay, so we have a number of participation rates, that clinic self-selection and also enrollee self-selection into HCHs that are changing significantly over time. Second limitation is that healthcare home effects may take a while to emerge because transformation takes a while to implement and to change patient behaviors, to change clinic, and to make them all work very smoothly. Measurement of costs and resource use we're continuing to work on. That will be significantly improved by improving the attribution of enrollees to clinics, and that is improving over time because of improved data, and we're also exploring some other data sources that will help us improve the attribution in 2010 and 2011. So we're trying to get those numbers and the number of people improved. So the next steps, we're going to include more data as it becomes available, like Medicare data. We're going to estimate the effect of the initiative on clinic transformation, and we're going to add data from the PCMH CG gaps for the patient experience. We're going to dig deeper into the disparities evaluations and the subgroup evaluations, and we're going to be improving our evaluation methods such as attribution, risk adjustment, and causal modeling so that we can finally determine as much as we can the causal relationship between the HCH initiative and the AAA. Thank you. Appreciated your time.
And thank you, Marie and Dr. Hooley, for your presentations. We will now have about 15 to 20 minutes for audience question and answers with the presenters. If you have not already done so, please type your questions into the drop-down question box on your screen. We will try to answer as many questions as possible in the time remaining. We have gotten already several different questions about the standards that are used to certify healthcare homes in Minnesota. One person was wondering that with 3 to 4 nationally vetted standards for PCMH, why did you go with state standards and certification process. Marie?
Hello, everybody. Well, in 2008, when we were first sat down to look at certification for Minnesota, we did evaluate the only set of standards that was available at that time, and that was the 2008 NCQA standards. And at that time, we decided that since we were really going to have a strong focus around patient and family-centered care, a strong focus around care coordination, and a strong focus around implementing quality, that the NCQA standards didn't meet our needs and were much more focused on IT and implementing processes. And while we didn't disagree with that, within our state of Minnesota, we already had legislation that said that by 2015, electronic health records needed to be implemented, and by 2013, e-prescribing needed to be implemented. So I think our goal was really to look at providing the roadmap, the guidelines for real primary care transformation and really giving primary care providers those tools. So then related to certification, our legislature actually asked us to develop a certification process, and we did that through a strong community engagement process. The clinics were involved, a number of payers, quality partners, and other groups, including consumers, were involved. And I think that really helped us related to having people engaged through implementation. The other thing we felt is that we do a site visit for the initial certification. And that site visit, true to our beliefs around patient and family-centered care, we bring consumers with us that we have contracted with, as well as providers in the community. And our certification process is less about looking at data and outcomes and all about looking at, is the processes, are the workflows, has the culture changed, is it really in place? And we didn't feel that we could feel and see patient and family-centered care and culture change unless we actually went out on a site visit, and that wasn't available to us in some of the other standards. We think that we review paperwork in advance to see if a clinic is ready. I've gone on over 50 site visits myself, and sometimes I'm fooled by reviewing the paperwork and looking at whether that true culture and transformation has occurred. Other times, maybe the paperwork isn't as thorough, and we go out and we see really active culture change. So that's the direction that we've decided to continue. We also do recertification team meetings and review documentation at recertification, and that allows us to really work with clinics as they're progressing and continuing their culture change. All done with that one.
And just to confirm, you do a site visit for every single health certification, don't you?
So for every certification, we do a site visit. So, for example, if you have a very large system that might have 20 clinics or so, we don't visit every single clinic. What we do is we look to the organization to tell us, have you implemented your healthcare home in a standardized way across all of your clinics? And then we look for those unique clinics. So we might go to a residency clinic and a clinic with geriatrics and a clinic that's smaller and one that's rural to get a really good sample. And then we visit with those clinics from year to year, a variety of clinics from year to year in recertification.
Thank you. So I think this question is probably for Dr. Hooley, but finance is important, but not the primary driver for a clinic becoming healthcare home certified. So what do you think are some of the primary drivers?
I think in Minnesota there was a lot of movement forward on improving healthcare that you see in the State Health Improvement Program for communities, the focus on electronic health record and interoperability standards and e-prescribing standards, statewide quality reporting measurement system, which I think had an effect because many clinics participated and they could see how they were doing to comparable other clinics, and I think that would motivate them to improve for professional reputation purposes, and also because they wanted to improve the care that they were delivering to their own patients. You also have very active health systems around here that have been working to improve healthcare, improve their systems, and I think the healthcare home fit into that. And finally, I think a critical part here was the way Minnesota went about developing the certification standards with a lot of stakeholder involvement, a lot of participation throughout the community, which developed a standard that the community bought into and made it fit its local environment. And so all of those made it a little bit easier, but you still hear that money's important and that has to be worked on with multi-payer payment. And the long-run sustainability might be affected by being able to make sure that they get paid for the care coordination.
Thank you. And just to build on that a little bit, are consumers involved in advisory groups for the Minnesota Healthcare Home Program?
Yes, they are. I'll start at the state level. We have a Consumer Family Council that has been in place since 2008, and consumers participate in all of our content-related work groups. Clinics are required to have consumers participate through the certification process. So consumers are required to participate on the clinic's either advisory committee or their quality committee. We often see consumers participating on their implementation committee as well. Sometimes it's difficult, though, to attract consumers, and so then we look to see that there really has been a strong recruitment method related to consumers. But there have been so many really creative things that clinics have done to really have patients and families participate in their healthcare homes, and I would say that that's been a strong driver in the state of Minnesota in implementing PCMH.
Thank you. So another question for Dr. Hooley, which is, in the estimation of cost, were the cost of all patients at the healthcare home site included in the calculation, or just the cost of patients who receive care coordination services?
All the patients that we attributed to an HCH eligible clinic or an HCH were included in that. It wasn't just the ones that we used. The care coordination charges as one of the rules for attribution, but we also used evaluation and management visits for attributing patients. So we included all the patients that were seen by the clinic.
And I think this is, I want to just add on to that, this is an important point. In Minnesota, when we're doing certification, we're looking at the clinic's entire population. And while we confirm that those care coordination processes are in place, we're looking at how are they managing their entire population, not only related to certification, but related to their quality benchmarking scores, because otherwise we might end up with unintended consequences. So we want to make sure that we're implementing PCMH in a population-based approach.
Thank you. So I see a number of questions here looking for your standards and for your the state plan amendment you submitted to CMS in order to operate the program. And I know that many of those are available on the Minnesota website. They're also available on NASHB's medical home map if you just click on Minnesota. So those are all available, and we can send out links afterwards. And then another question we have is that primary care clinics are undergoing many transformations, not just the healthcare home certification. And the question is, have you explored what changes the non-healthcare home clinics were engaging in during this period?
Well, that's a really good question, and we know that a lot of the non-healthcare home clinics are in process of transformation on all sorts of levels. including some of the things that Dr. Hooley mentioned around implementing their electronic health records and even implementing the healthcare home themselves. And so it's difficult to know exactly what is the broad level of transformation that's occurring, but the statewide quality measurement reporting system is required for all the clinics in the state of Minnesota. And so there is a lot of other transformation going on as well, which actually complicates our ability to really have a clean evaluation, because our comparison groups are doing a lot of transformation as well.
And in our models, we do control for time to allow for a history effect, that there's continual improvement throughout all primary care over time. And so you control for that. Everybody is becoming better. So you control for that, and we did control for that, and we still found a significant healthcare home effect. So we're going to be trying, in our next phase of the research, we're going to be digging into this a little bit more. And the other question that we want to be digging into is, even for the healthcare homes, what type of a burden does this place on the clinics to transform and to keep on transforming? And so we're going to try to explore that a little bit more deeply to understand how HCH eligible and HCH clinics are different or similar.
Thank you. We have several questions that are picking up on your report that the rural clinics were less likely to be certified. Several people are asking for your thoughts about why they might not get certified, what advice you might have to others, and any actions that you in Minnesota are taking to address the needs of the rural areas. And Marie, you might want to start with that.
Yes. Well, I think early on, the study goes through the first 3 years. Now in 2013, we have seen a real increase in the number of certified healthcare homes in rural Minnesota. If you recall the slide that I showed that showed all the states, you'll see that in southwestern Minnesota, where it's predominantly very rural, really they have the most certified healthcare homes per 100,000 people at this time. So we are actually watching that very carefully, and some of the strategies we put in place is that some of our healthcare home nurses live and work in northern Minnesota and in southern Minnesota. And so we actually have capacity building staff located in rural areas within Minnesota, and those nurses that have experience in working with rural clinics. I think the other thing is that we have a lot of large systems in Minnesota, and so the systems were geared up and doing transformation and innovation and moving forward more quickly. And I think that's a natural trend for us across the state related to how implementation happens. So I think the next time we look at this report, and if you looked at the map today, you would see that we're continuing our work, and we focused our efforts around ensuring that rural Minnesota is coming along as well.
Thank you. And then we have some questions about some specific things that you might have looked at in your evaluation. So Dr. Hooley, did you look at the preventable admissions and readmission rates per 1,000?
We have not done that yet.
Okay. And then there was another question about how you, in your quality slide, looking at the diabetes outcomes, is how did you account for individuals with multiple chronic conditions that impact specific diabetes outcomes?
The measure was the average, or the Grand Slam measure of the 5 measures. And in the models that I've run, we have controls for comorbidity of depression, and I have a control for comorbidity of vascular disease. That's all the data that comes in on the statewide quality reporting measurement system. I also have age and gender differences. Okay, so those are the controls that we have for some comorbidities, the major ones.
Okay. And I think we have time for one more question, and we'll make it a big one, which is, can you explain the role of the healthcare home nurses?
Great.
Yes, I can. You know, our healthcare home nurses have been integral to our success around implementing the healthcare home. Not only are they out in the community and really working with clinics, explaining the standards, talking about change management, talking about culture change, and working with clinics in partnership in lots of different ways, but they are key members of our certification team. So when we implement a certification, certification site visit, it's our nursing staff that is the partner to the clinics all through the certification process, starting with reviewing their documentation, going out on the site visit, pulling together all of the feedback from the site visit, writing the report, making recommendations to our certification committee and to the commissioner, and then setting a follow-up plan with the clinic related to, well, then what additional needs and resources do they have for the future? And so my feeling is that we have identified the best role. Our registered nurses, most of them have a lot of experience being nurses, working with clinics and systems and quality. They have been key, absolutely key to our certification process. And the clinics, we get lots of positive feedback from their work with the clinics related to their support.
Okay. Thank you. And thank you, everyone, for joining us on today's webinar. I'd also like to extend a special thanks to our presenters for joining us to share their expertise. As a reminder, the slides and recorded presentation will be posted on PCPCC's website within the next 24 hours. Once available, you can access them at www.pcpcc.org/webinars. NASHB will also link to the archived webinar on its website. So we hope that you can join the PCPCC's upcoming national briefing on April 24th, which will feature results from Independence Blue Cross's PCMH initiative and the multi-payer advanced primary care practice demonstration programs. And with that, we will sign off and wish you all a pleasant afternoon. Thank you.